Hello everyone. In today's session, we'll be talking about screening of aneuploidies in first trimester. So through my video, I will try to summarize how you generally screen for aneuploidies, and I'll also show you some of the doubts and practical aspect how to solve it. So stay tuned with my channel and let us see how we solve the tricks of aneuploidy screening. Today's session will be talking about aneuploidy screening. So what do you actually mean by aneuploidy? Aneuploidy means certain chromosomal abnormalities which can occur in the fetus. So certain tests should be done, that is mostly the screening tests, which should be done in all pregnant patients so that we come to know whether there is any aneuploidy in the fetus. So for aneuploidy screening, always remember we can screen the mother in both first trimester as well as second trimester. The basic idea of screening is that if we find the baby to be having certain anomalies, then we will go for diagnostic test and we can go for medical termination of pregnancy. Now, our recent MTP Act says that if the period of gestation is less than 24 weeks, we can go for MTP if there is any anomaly or abnormality in the fetus. So, all the aneuploidy tests should be done at a gestation less than 24 weeks, because doing a test or a screening or a diagnostic test at a period of gestation more than 24 weeks will not help the mother or the baby, because we cannot go for MTP in that instance. So now let us see what are the first trimester and second trimester screening tests. Always remember, if somebody asks you in exam, it is a very common question which is asked, always say that we have certain biophysical markers as well as certain biochemical markers. Biophysical markers are in the form of ultrasound. So ultrasound is done both in first trimester as well as second trimester, and biochemical markers are done also in first trimester as well as second trimester. Coming in detail about the first trimester. In first trimester, when you get an ultrasound done for aneuploidy, remember, always advise the mother to get it done between 11 to 13 plus 6 weeks. This is because the crown rump length of the baby is between 45 to 84 mm at that time, and this crown rump length of the baby is very much necessary because it is at this point that all the aneuploidies are best picked up. So always advise mothers to get an ultrasound done between 11 to 13 plus 6 weeks. Now let us see what all things we look for in an aneuploidy screening. It is also called level 1 scan in certain labs. So 5 things we look for here. Very important, always remember. First is NT, that is nuchal translucency. Second is your NB, that is nasal bone. Third is your maxillofacial angle. So what is maxillofacial angle? If this is the baby's face, then this is the maxilla and this is the frontal bone. So the angle between frontal bone and the maxilla should be either acute or less than 90 degree. If it is more than 90 degree, that is if it is obtuse, then there are chances of aneuploidies. So it should not be obtuse. The fourth thing which you look for is tricuspid regurgitation. If there is tricuspid regurgitation in the right heart of the baby, then it says there is heart failure, and so such babies are at chances of aneuploidy. And fifth is your ductus venosus A wave reversal. So if there is A wave reversal in the ductus venosus, then this is also signifying aneuploidy. So always remember, in certain labs they give only nuchal translucency and NB values. They do not mention about maxillofacial angle, TR and DV. So those scans are not to be relied. All 5 things have to be told. Okay, very important. So this is all about ultrasound in first trimester. Now coming to biochemical markers in the first trimester. In biochemical markers, always remember, we have 2 markers. One is your PAPE. PAPE is placental associated plasma protein A, and second is your free beta HCG. So these are the two markers which we look for. PAP value is decreased if there is trisomy 21, and beta HCG values are increased if there is aneuploidies. So PAP, now how much is decrease? This is very important because थोड़ा सा decrease में भी ये decrease हो रहा है, ये थोड़ा सा increase हो गया तो भी increase हो रहा है. So all these serum markers, we count it by the unit of mom. Mom is multiples of median. So if you look at the graph, if 50th centile वाला graph जिस point पे है, if that is the appropriate for that gestational age, so if 50th centile वाला graph पे हमारा value आ रहा है, then we say it is one multiple of median. So median value पे है. If it is less, if it is half of that value, then we say it is 0.5 mom. If it is double of that value for that gestational age, then it is 2 multiples of median. So that is why we calculate it with the mom. That is what should be the standard at that gestational age. So let us see how much PAP should be decreased and how much free beta HCG should be increased. So PAP should be decreased to less than 0.4 mom. Then we say कि PAP का value significantly low है and there is chances of aneuploidies. Free beta HCG should be increased to more than 1.8 multiples of median. Then only we will say कि free beta HCG is significantly increased and there is chances of aneuploidies. Now always remember, PAP value if it is less than 0.4 is prognostic marker of one is aneuploidy जो हम आज के क्लास में पढ़ रहे हैं. दूसरा है मैटरनल रिस्क भी होता है. देयर इज चांसेस ऑफ प्री एक्लेम्शिया इन द मदर एंड FGR इन द बेबी. सो इट मे सो हैपन दैट बेबी डज नॉट हैव एनी एन्यूप्लॉइडी, फिर भी PAP वैल्यू लो हो सकता है बिकॉज mother might be having some underlying vascular disorders, like mother may be a case of SLE in pregnancy, or mother might be chronic hypertensive, or her age may be increased, and so this lady might land up in preeclampsia. So this is a screening marker for preeclampsia also, as well as FGR. So this is to be remembered. And free beta HCG more than 1.8 mom. Now what we do is, generally in pregnancy we have various kinds of screening modalities like dual screen, triple screen, quadruple screen. In first trimester usually get a combined screen done. What do you mean by combined screen? Combined screen means you will take some history indicated markers. Number 2, you will take some ultrasound markers and you will combine it with biochemical markers so that the sensitivity is increased. So what are the history indicated markers? History indicated markers. Now let us look at this report. Now this is a lady who has come. This is a combined screening report. Now see what all things are seen in history. Number 1, fetuses. Number of fetuses, whether it is one fetus or it is multiple pregnancy, these all things are looked at. Next, the weight of the lady. If weight is more, then she is obese and she might have more chances of aneuploidies. Then whether there is history of smoking present or not. Whether this is an IVF pregnancy, because IVF pregnancies will be associated with multiple fetuses and there will be increase in beta HCG. Next, diabetes. Diabetes may be associated with vasculopathy and vasculopathy may result in chronic hypertension and preeclampsia, and so diabetes may lead to falsely low PAP-A also, and so these things have to be ruled out. Next, the origin of the lady, whether she is Asian or whether she is Caucasian, whether she is Mongoloid or African origin also matters, and whether there is previous history of trisomy 21. So very important in examination. If they ask you about combined screening, always remember in history what all things we ask for. One is number of fetuses, weight of the mother, smoking history, whether this is an IVF pregnancy, whether there is diabetes or not, needing an insulin, origin of the mother, and history of trisomy 21. Next, coming to the ultrasound markers. In ultrasound markers, we take NT, that is nuchal translucency, into consideration. So see, nuchal translucency and nasal bones have been taken into consideration. And also we will also take the biochemical markers. In biochemical markers, as I have already told, we will take PAPA and free beta HCG. Now see, it is very important to look for the mom values, corrected multiples of median. So you see PAPA is 0.8 mom. So 0.8 mom is normal because less than 0.4 mom is abnormal. Next is free beta HCG. Free beta HCG is 0.94 mom. So 0.94 mom is also normal because more than 1.8 mom is abnormal. So you find that both free beta HCG and PAPA are normal. So finally we will combine all the history, ultrasound and biochemical marker, and we will calculate the final risk of aneuploidy. If the final risk is more than 1:250, then it is high risk for aneuploidy. Always remember, if it is between 1:250 to 1:1000, then it is intermediate risk. And if it is less than 1:1000, then it is low risk of aneuploidy. So you find when we have added it up, then the combined trisomy 21 risk is 1:3783. So it means it is low risk, that is less than 1:1000. But and the trisomy 13 and 18 risk is less than 1:10,000 is also low risk. So this fetus is at low risk for trisomy 21, trisomy 13 and trisomy 18. Trisomy 21, 13 and 18 are the trisomies which are non-lethal, and babies are usually born with these trisomy, which adds to the morbidity. So we will screen for these. If you look for other trisomies like trisomy of chromosome 6 or trisomy of chromosome 12, these are lethal abnormalities. So babies generally die in utero and they end up in abortion. So you need not to think more about them. So this is how we look, and this is the cutoff which is generally used. I told 1:100, 1:250, 1:1000. These all markers are used, and so more than 1:250 is high risk. Between 250 to 1000 is intermediate risk, and less than 1:1000 is your low risk. So this is how you calculate. Absolute values of PAPA and free beta HCG are not important until and unless you convert it to multiples of median. So is it clear to everybody how we interpret a biochemical report of first trimester? Now, one very interesting case which I'll show now is this lady. Now this lady has come with a report showing that the combined risk for trisomy 21 is 1:94. So this is high risk. 1:2 because it is more than 1:250. So it is high risk. And trisomy 13 and 18 risk is 1:6475, which is low risk. So what we are concerned now is risk of trisomy 21. Now, if you just look at this report, you will tell the mother ki this is a high risk baby and let us go for MTP. But it is wrong. You cannot just advise the mother looking at the risk. This is what is happening. We never even bother to look at the multiples of median. Now, see nicely this report. The PAPA value is how much? 0.29. So PAPA is low for this mother. Why? Because it is less than 0.4 mom. Free beta HCG is 1.23 mom, which is normal. So your free beta HCG is normal. Then also look for this. Weight of the mother is 55 kg, which is normal. Fetus 1 fetus. She does not have any history of smoking. Then this is not an IVF pregnancy. She is not diabetic. She is Asian origin, and there is no previous history of trisomy 21. So all history indicated markers are also normal. Then come to NT and NB. this nasal bone is present, which is absolutely normal. Nuchal translucency is also normal, 1.2 times mom. If nuchal translucency is increased, if it is more than 3 millimeter or more than 90th centile of normal, then it is abnormal. This NT, this mother's, see, this is the ultrasound report I have brought. The NT is only 1.9 mm, so it is normal. So see, every marker is normal except for this PAPE, which is 0.29 mom. Except for this low PAPE value, everything is normal in this mother. Now what I have told, PAPE can be reduced in what all conditions? Number one, it can be reduced in, one is your trisomies. The second is if mother is at high risk of preeclampsia and FGR. Now, don't you think this mother, that baby might not be having trisomy because NT-NB is also normal, age related everything is normal, free beta HCG is also normal, only PAPE is reduced. So it might so happen that there is no trisomy and mother is at high risk of preeclampsia or FGR because of any vasculopathy. Underlying vasculopathy can be because of autoimmune disorders, can be because of SLE, chronic hypertension, such things. So you are falsely advising a mother to go for MTP when the baby is absolutely normal and the defect is in mother. So always remember, when you have such type of report, do not directly go for MTP. Get an amniocentesis done for the mother. In amniocentesis, what we do is we take mother's the amniotic fluid from the abdomen and we do karyotyping. If you do a karyotyping in the amniotic fluid, you look for the fetal chromosomal status. If you get trisomy 21, then you are 100% sure that baby is diagnostic of trisomy 21, then you can go for MTP. Otherwise, as far as this report goes, this baby might be normal and in that case we will not get trisomy 21 in this mother. So you have to advise the mother that baby is absolutely normal, there is no Down syndrome in the baby, need not to go for MTP, but you have to screen the mother for preeclampsia and FGR. So close follow-up is required and you have to start ecosprin for such patients. Ecosprin has to be started 150 milligram once daily from less than 16 weeks. Then only you can prevent the vasculopathies and you can prevent preeclampsia. So I wanted to just highlight that it is very important to look for the multiples of median also. Never only look at the final report कि ये low risk है कि intermediate risk है कि high risk है. It is better to see the interpretation also, but apart from that you have to look at the multiples of median also, so that you can clinically diagnose even the smallest of the abnormality, whether it is in mother or the baby, and accordingly you give your judgment and you become the best obstetrician.